I want to talk to you this morning about a very recent change, obviously, due to the pandemic, a change in the entire state and to a large extent across the country, but in particular, this refers to Detroit and Wayne County. I think we all know that in March, an executive order by the governor went into effect, which changed a lot of things. But in particular, what it did was allow for community mental health providers in the state of Michigan to submit invoices for services that they provided under a modified telemental health. Now, telemental health by itself or telehealth by itself is always a face-to-face done using Teams or Cybex or Zoom or some other sort of face-to-face kind of virtual provision. This actually allowed services to be delivered by telephone as well. Telemental health is not new. It's been around for about 20 years. It's used primarily in rural areas where transportation is difficult and takes a long time for consumers to reach providers or providers to reach consumers, and so they allow for telemental health. But it's never been used very much at all in the state of Michigan, and certainly not from the standpoint of being reimbursed. Locally, the Detroit-Wayne County Integrated Health Network, and that's the system of providers in Detroit-Wayne County, they authorized full telemental health implementation, which essentially meant that there would be full reimbursement for all services rendered in that manner, rather than a differential reimbursement because of telemental health piece. And so all the providers moved to predominantly deliver services remotely. The unknowns that really were being faced here were what effects would these changes in service delivery have on a population of severe mentally ill adults and severe emotionally disturbed children, a very vulnerable population, a population that has difficulty functioning under ordinary circumstances, certainly now functioning in a pandemic, and even more so with services that were being rendered to them remotely. So we began to look at and wanted to look at three things. One, the service array. What were the changes in services in the manner of delivery of service, and how would that affect the services that consumers received? Secondly, we wanted to look at outcomes. What was going on in terms of the actual functioning and symptoms that the consumers were experiencing, particularly were they continuing to function as they did before COVID, or was there some decline in functioning and increase in symptoms? We also wanted to look at health disparities. A big issue right now in all of health and healthcare is looking at particular disparities. So we wanted to examine all these unknowns. The population that we looked at represented almost 13,000 adult and child consumers that were served by four very large providers in the system. And the three areas, I'll go through them very quickly, of health disparity are certainly race, ethnicity. We know that there are significant disparities here. And this is the breakdown among the four providers. Principally Black or African American, with some Caucasian, and notice that Latinx is about 9.5% of the population consumers. Sex is the second principal priority in terms of health disparities identified by the Substance Abuse and Mental Health Services Administration, and this was the breakdown in terms of sex. And the third area identified by SAMHSA is sexual orientation or identity status. So we were looking at all three of these to see whether or not only what the changes might be in services and in functioning and symptoms, but also were there any differentiation among these factors. We looked at over 200,000 services. Major categories were psychiatric services, case management, and outpatient therapy. In outcomes, we looked at functioning and we looked at symptoms. We used three different time periods: the time period prior to the transition to telemental health, a period identified by the four provider systems of 2 months, where they thought that everybody was kind of getting used to this process, both the providers and the consumers. We had daily data by consumers, and we used a repeated measures analysis. We also had a post-transition time period as well, which was the period of time after this identified 2 months. So what did we learn? Well, consumers have and prior to the state order, had about 1.5 appointments or contacts per month. And these contacts actually typically reflect more than one service per contact. What was interesting was that it didn't decline significantly at all between the pre-state order and the transition, but began to decline after the transitional period. It's not really significant. You see significance down below because of the number of people we're working with and the number of services that were involved. But frankly, from a practical standpoint, that it didn't really change much. What did change significantly was the amount of time that consumers spent with their provider. Probably because of the nature of the service provision, both on telephone and on Zoom, for example. We all have trouble. We've learned this quite well. Certainly our students sometimes have trouble maintaining contact and engagement, and it's no different at all with the service population that was being worked with here. And then there were an average number of minutes for the services that were being provided during that contact actually decreased as well. From a functioning standpoint, we looked at 3 standardized measures. What was interesting here was, in spite of the fact that contacts went down somewhat, time went down very noticeably. The fact is that the consumer, at least from a child standpoint, continued to improve. So it didn't seem to affect the level of improvement. Lower scores are preferred here. We'd like to get children down below a score of 50, and they actually did decline in score, which is good. Same thing was true among adults. It wasn't as profound, and there was a little bounce back between transition and post-transition. The fact of the matter is that adults also showed an actual increase in functional capacity. And the same thing was true in symptoms. The PHQ-9 measures depression and some anxiety, and that continued to decline as well. So in spite of the fact that patients were getting less service, they managed to improve in terms of their symptoms and their functioning. So contacts remained relatively stable. The duration diminished. The duration of services provided diminished as well, but there wasn't any differential effect in terms of health disparity. So there was no difference among those groups in terms of the contacts, the duration, or the duration of services. Same thing was true in terms of functioning and symptoms. In spite of the reduction in contacts and in time, consumers continued to improve. And again, there were no disparities, which is good. Next steps, we're going to look more deeply at the services. I mentioned that the 3 major services were psychiatric, case management, and outpatient therapy, but some services that are not included in that list, for example, a lot of home-based services and community-based services, we're going to look more closely and see which of those were actually more resilient to the changes and which were more vulnerable. We're going to do the same thing in functioning and symptoms. We're going to look inside all those measures and see which factors were more vulnerable and changed the most, and which ones were more resilient and actually improved significantly. And the last thing we have done is to gather a lot of data from interviews with both consumers and providers, the therapists and the case managers. And what we want to do is to be able to code those. It was not enough time before this presentation to do that. But by the end of November, we suspect that we'll have all of the qualitative data coded and be able to make some kind of educated advance in terms of knowledge and in terms of what really happened, the actual experience that people went through during this year that we studied. Thank you very much.